2020, the year 2020, 66% of our population is going to be dependent on the workforce. All right, so the 18 to 64-year-old group will be supporting not only those less than 18 years old, but those greater than 65 years old. So there's going to be a tremendous amount of pressure put on that group to care for 2/3 of the population, okay, in some kind of support level. That's generalizing it a little bit, but that is just an unfathomable number when you think about it. Both from a positive and negative standpoint, what do you think is going to happen based on some of these things happening in the Affordable Care Act, and where are you focusing to grow your businesses and to ensure that you thrive and moving forward? So
we're actually the second busiest hospital in the state of New Jersey based on same day and overnight admissions. We treat 50,000 patients yearly. We have over 75,000 visits to the ED, perform 18,000 surgeries, deliver over 3,000 babies, just to kind of give you an idea of the type of organization that we are. The issue, as you think about it for a hospital, is when you think about the offerings that are now out there. As people migrate to some of the plans on the exchange, what it means is that the reimbursement for those plans to providers, to hospitals, home care, to physicians will be lower. So we believe that the net impact will actually be a negative, just strictly speaking from a financial standpoint. And the way we are preparing for that is really looking at how we deliver care, aligning directly with our physicians in a large multi-specialty practice, and really getting control over our costs.
The first kind of major shock to the industry was not the ACA. It was the financial crisis. And there were a number of things that were happening across healthcare in the U.S. and around the globe that financial crisis just accelerated fairly rapidly. And so if hospital spending, I'll use the U.S. as an example, was growing about 7%, if you went back 5 years ago, it dropped very quickly to about 3%. And so you had a major change in the growth rate in the device markets because hospitals started spending less. Now, in addition to that, we started to see a very rapid uptick in hospitals buying physician practices.
Historically, it's been a very tumultuous relationship. There's a long history of hospital systems buying physician practices and either one or the other party becoming pretty unhappy with that relationship. Either hospitals ended up paying too much for the physician practices, or the physicians found themselves in a system that they didn't really know how to navigate in a way that made them happy. I think here, this time is different, and it's different because our IT systems are different than they were before, so we have probably better ways to manage what physicians do and provide them better information, and better payment systems for the physicians to align their incentives to kind of get everybody on the same page. That being said, I think the ultimate goal here is to provide some population health management. Payments are going to be more bundled and spread across, encompass more services, and that means healthcare systems are going to have to figure out ways to population health manage. Physicians do not know how to do that. I think systems are learning how to do that, but they're just starting. They've never had to do it before, and it always takes a while to learn. I think the fundamental challenge and whether these integrations are going to work is going to be based on whether can actually kind of align incentives within these organizations in a way to manage population health that works for everybody. And I think, that it's not obvious to me that will actually happen.
I would say it is different now in terms of the physician alignment strategy. You have physicians coming out of training who are not looking to do what maybe their parent had done, setting up a private practice. They want to be aligned directly with an organization that's large. They feel comfortable in that environment. I think their expectations are different. So I think the younger generation is easier to integrate. So you might be thinking about, well, what about those folks who've been practicing for decades? And we actually have aligned with those individuals, and I think we have created a vision of what healthcare could be and how working together will ultimately serve both parties, and that in the end we'll be able to provide better care, and that's more coordinated.
The 90s wave of physician acquisition, they kind of paid them salary and didn't provide much incentives, and that's kind of why they retired, because there was no reason to work hard. I think that the compensation mechanisms are much more sophisticated, and the hospitals have learned from their mistakes.
So a key element of compensation is base salary, but we always build in an opportunity for physicians to achieve bonuses, the same way we would do that with executives, so that it will include elements such as quality improvement initiatives. There may be some productivity-based elements in it as well. And we are actively engaging the doctors in leadership. Serving on the board, which I think is important, having a leadership council of all physicians. So we are really trying to make our organization feel different to the doctors by saying that we are going to have a physician-led organization that's professionally managed.
If I go back, 7 years ago when I became chairman, the attitude of the physicians towards the hospital, employing physicians, of course, they were very, very concerned about any move in that direction. So as hospitals around the country started adding hospitalists, this was, what's going on here? You're going to compete with me. I'm really concerned about this. The attitude today is totally different. It's, I'm at your door, I'm knocking on your door. How are we going to do this? This game is changing rather dramatically. And so we want to make sure that we're part of a solution that's going to be a winning solution. And so you have a very different dialogue with the physicians than you had, 7 years ago. And if you went back to what you were talking about, I think this is really different from the foray in managed care back in the 90s.
And I think the physicians are looking at the economics of private practice in our community. Physicians practice for so many years as solo practice, maybe, there's onesies, twosies, and the economics just aren't there as you have to implement IT systems. They just didn't have the wherewithal. So I think it makes it maybe a little different, although I'd like to hear from Bob of what's going to make it fail so we can, maybe take a different path.
The risks are getting the incentives aligned. How do you get the incentives aligned so that physicians can practice the medicine they want and get paid the salaries they get paid? And hospitals make money to cover their investments, and I think that's a very tough combination. I think at the after the integration, it's natural to look to cut costs, and one natural place to look is physician salaries. And once that happens, I think the harmony may become a little bit discordant.
And some of this stuff almost speaks to organizations like Kaiser, where they've integrated really well. The institution and the providers. I mean, do you see more of those kind of alignments or even types of systems coming, actually starting or actually succeeding?
Yeah, I think that, the history of, health policy is, always looks to Kaiser, right? I mean, for 30 years, well, Kaiser can do it. We should be able to replicate that everywhere. But you can't.
But talk a little bit about what Kaiser has done successfully.
Kaiser is able to kind of own the patient. I mean, one of the important things about Kaiser is that their patients stay there. They lose very few patients, so they have low turnover, and so they can actually population manage. They can take the long view on their patients and not the short view. And as an insurer, that's a huge advantage. And they're able to kind of align the insurance incentives with the healthcare incentives, and align the providers with the patients, and that's fantastic, but it's very hard to do. Kaiser's been around since the 30s, and I think that might be the necessary condition, is to start an organization that's 80 years old, and you might have some chance to do that. Now, there are other organizations that do a very good job, guys, you know the names, but they're few, right? And they tend to be in rural areas. They're Mayo and Geisinger and places like that. So, Intermountain Health. So those, I think, are, the circumstances are important there. I mean, I don't think you can easily replicate those models just everywhere. And so I think there's lessons to be learned from those models, but they're very difficult to implement in places that are disintegrated and didn't start from kind of this integrated vision.
When you look at that model, it also appears that they have made an enormous investment in information technology and the ability to gather data from that patient base and then create clinical pathways and best practice. That's not going to be easy to replicate. But where do you see that all going, that side of it?
I think that's going to be central. I mean, I think that's, this time is different, is that we have IT systems, we have methodologies to analyze the data in ways that we didn't have before. Yeah. So we're able to kind of identify, who's a patient at risk much quicker. And we have, we know what interventions work, and we can bring those interventions to bear quicker. And so those factors are going to be, I think, very important. I also want to mention that Kaiser also spent a huge amount on IT that failed.
Yeah, sure.
I think $1 billion, and they had to throw away $1 billion IT system. So, they've had their challenges as well.
Sure.